These are two cases that I'll be presenting. Pretty unusual. I haven't had, at least the first one, I didn't experience it before. This is a 55-year-old phakic male, sudden diminution of vision of 1 day duration. I wasn't around, so I was traveling. My colleagues thought that she would better offer a pneumatic retinopexy, and then avoid a vitrectomy in this case. So this is how 24 hours after pneumatic retinopexy, but the colleague could not achieve a good laser of this causative break. So 48 hours after injection, this is a kind of the RDS progress, the subretinal gas. And at this time, we offered a vitrectomy surgery, and this particular patient we planned I promised him that we'll be doing it under gas to prevent any recurrence, to prevent any resurgeries for another removal of silicone oil. So this is how it was: gas bubble in the vitreous cavity, as well as some in the subretinal space. 72 hours, this amount of vitritis also is developed. Initially, I did not give too much importance to how I'll be removing the subretinal gas because I thought it would automatically come down in some way or the other. Okay, and then following vitrectomy and trimming the retinal flap, indentation vitrectomy was done to remove the vitreous base indentation. And then you can see all these bubbles separately. Even that time also, I didn't give too much importance how they'll be coming out. I thought through the causative break that is there at 12 o'clock, they would be easily coming out once I inject PFCL. So PFCL was injected. It was difficult they did not come out through this break at the 11 o'clock. So fluid gas exchange, was being planned, air fluid exchange. And after air fluid exchange, you see that, some bubbles are still there and in the same position and they are loculated. And for some time, I thought I'll do laser around. You can see that they got coalesced to something. You can see this is a laser bubble anterior to the break. I thought I'll just barrage all these bubbles and then leave them like that. But this, of course, small gas bubble that did come out through the break. So that was sorted. So there are bubbles in the inferonasal quadrant. I thought I'll try to move them into this position, but instead of displacing along my area of interest, they progress posteriorly. And I was in a spot here, and for some time again I thought I'll do a barrage around this gas and then leave it alone. Then I realized it's not a great idea because they are expansile SF6 bubble, and even while barraging I couldn't do a complete. There was some amount of probable SRF around the gas bubble, so I could not laser one edge, the posterior edge of this bubble. So any manipulation was further decreasing. At this time I did a retinotomy and drained it to through the retinotomy. And then subsequently SF6 gas was injected in this particular case, and the feathery cataract disappeared and is doing well at this stage. The second case is of a 65-year-old female, pseudophakic, diminution of vision for 3 months, some amount of anterior uveitis and retinal detachment with shallow choroidal detachment. And you can see inferior pigments and mild PVR grade B. She would offer a vitrectomy surgery. So 25 gauge. 3 minutes, this is an edited video into the vitrectomy. I realized that there were few choroidals increasing in the periphery. So I knew there was shallow choroidal, but they increasing in the periphery. At this stage, I thought it could be a suprachoroidal hemorrhage. And through the resight, without taking out the resight, I was indenting and seeing if the cannula is in position. I realized there is a cannula in position, but that cannula was the other active port. So one port, probably during the surgery, it got retracted and went into suprachoroidal space. So this is something that could have been done differently. So I removed that, put in a 6 millimeters cannula, and then ensured that it's in place in the vitreous cavity. Now the important part is draining the choroidal. I did convert to 20 gauge as was my experience before, but it couldn't really drain much of place. So I did drainage through trocar, through the valveless trocar and periphery, and posteriorly. It did resolve initially at first placement, it did choroidals reduced, and while removing tangentially, slowly removing and pulling it apart, the choroidals got almost drained, the posterior valveless trocar. This has been my favorite technique of draining choroidals or suprachoroidal. It has worked well for me. But on this day, I was going to have a surprise after this. I could see that there was some hemorrhage in the periphery. During further PFCL, then I was more surprised that breaking the PFCL, the hemorrhage was going posteriorly, subretinally. So this is how it was. And at the time, I planned urgent laser, 360-degree barrage was done, and all 360, and you can see that some loculated subretinal hemorrhage in the periphery, and I also cryoed probably the causative break somewhere. So after doing this thing, I asked my colleague to take over and just do fluid gas air PFCL exchange and silicone oil injection. So it so happened that while ideally PFCL silicone oil exchange should have been done. So while removing the PFCL, we slowly see that that hemorrhage in the periphery is coming down posteriorly and shifting posteriorly, and I think video stopped. Yeah, posteriorly, and almost at the time of complete removal, it is almost submacular hemorrhage. So quickly at this time, I did a retinotomy at that site. And removed the subretinal hemorrhage that was still unclotted. Yeah, so it did easily come out, and that's how I saved the day for myself as well as for the patient. Yeah, this is how it is post-operatively. It's doing good, and subsequently after 2 months, and she's scheduled for silicone oil removal. Thank you.
Thank you, Dr. Reddy, for your nice presentation. Any questions from the audience or any of our instructor, please?
The first case, there were two small bubbles which actually collapsed and became one big bubble.
Yeah.
Even if it had left it, it would not have caused a recurrence, I feel.
There was some. That is 100% SF6.
100%, okay.
Yeah, 100% pure SF6. At the time of injection. 72 hours. 72. We tried. Yeah. I did.
Expansion.